Good evening, everyone, and welcome to today's wonderful evening with Dr. Murali Bharadwaz. And let us revise preventive medicine. So, we already revised around 300 plus points. There are totally about 4,000 points, right? So, sometimes preventive medicine is very slow and sludging, but there are points that are going to uh, make a lot of difference. So let's make the great beginning. Can the online students can punch whether the voice is loud and clear? Now, ecological study. It is also called correlational study. It's a observational study, but it is the least satisfactory type of study when it comes to evidence. So in the evidence-based medicine, we depend on case control, cohort, cross-sectional, and ecological study design. There are various designs, as all of you know very well. So ecological study is the least preferable observational study is what you need to basically remember. Least preferable. In ecological study, what you are taking is the group level, and you're trying to find an association between two variables. You're taking one entire country, and the entire country's average dietary fat intake per capita. I may not get food at all. Another fellow may be overeating. But overall country's average dietary fat intake per capita and breast cancer rate is compared. That's the reason it is not a very good study design is what you have to basically remember. So the unit of study in ecological study is population. That is what you need to basically remember. Ecological study, you do it in a very small time frame, and it is very inexpensive. And what you need to do, you just need to go and then pick up already the national data available. On one side, you have the breast cancer data, another side, fat intake data. Just compare the two. Very easy. So use the data that is already available. That is what you are doing in the ecological study. Unlike a cohort study where you are following up for a long period of time, that is not what you do here, is what you need to remember. Now, what is the advantage of the ecological study? You are comparing the entire population's average. There's a reason Sri Lanka versus Indian population versus Chinese population. So populations with different characteristics can be compared in ecological study. That is the advantage. But what is the problem of ecological study? There is a lot of socio-economic confounding. For example, if you are studying cervical cancer is more common in the lower socio-economic group. Lower socio-economic group. Similarly, you are trying to compare rheumatic fever statistics. Rheumatic fever is more common in the people who live in the crowded conditions in the single room, 10 people. So that is the reason. Socio-economic confounding. You don't know whether it is because of rheumatic fever in, for example, is found to be more in China compared to France. You are compared the population. You thought that it is because in China people do more smoking than the France. But actual reason why rheumatic fever in China is high is not because of more smoking. More smoking may be there, but it is because of that overcrowding because of a lower socioeconomic status. So that is the reason the potential problem of the ecological study is socio-economic confounding is what you need to basically remember. Now, what is the ecological fallacy of ecological study? Basically, ecological study is most fallacious method of study because you are taking the characteristics of the group. It's like saying all Indians are lazy, all Indians are brilliant, all English medium students are super duper, all government school children are poor studying. No, there are bright guys in the government school. So that's the reason ecological study is you are trying to generalize the entire population variables and characters onto that individual in the population. That is the ecological fallacy of the ecological study, is what you need to remember. Now, various studies, what are the parameters that we will be able to calculate? Favorite MCQ in exam. In cohort study, can you calculate incidence? Yes. Relative risk? Yes. Attributable risk? Yes. Population attributable risk? Yes. Case control study, only odds ratio. You can't directly calculate relative risk or incidence. Cross-sectional study, you can only calculate prevalence. Ecological study, you can get the group characters. So this is what you need to basically remember. Now, if you look at the ability of a study to prove the causation between the risk factor and the disease, randomized control trial is very strong. Then is cohort. Then is case control. Then is cross-sectional. Lastly, you have the weakest study design is ecological study, is what you need to remember. So that is the reason you should know certain important points about each of them. You are investigating a rare disease. You can't do cohort study because you can't get 1,000 people with Creutzfeldt-Jakob disease. That's the reason case control study followed by ecological study is the best for rare disease. Then comes you want to test multiple. Now, the another thing, you are investigating a rare cause, not a rare disease, but a rare cause, right? Rare cause means, for example, Ebola virus. Ebola virus is a rare cause. You are investigating Ebola virus means cohort study is better, right? You know difference between rare cause and rare disease. There is a fix in that. If examiner says what is the best study design for rare disease, what is your answer? Case control. If the examiner says rare cause, cohort study. Please don't forget, right? So the whole secret of preparation for entrance exam is these fine points you have to catch. Tomorrow exam, everything, these things matter. You want to study multiple effects. You suppose smoking, height, weight, employment status, 5 to 7 characteristics simultaneously if you want to study, then cohort study is the best one. Similarly, you want to study multiple exposure. So there are two things, exposure versus effect. Multiple effects, it is cohort study. Multiple effects means smoking can cause cancer, pneumonia, emphysema. So multiple things, multiple effects if you want to study, then cohort study is better than followed by cross-sectional study. Be very careful on these tricky points. 1 minute. Yeah. You want to study multiple effects, then cohort study is better than cross-sectional study. But you want to study multiple exposure. Exposure means risk factors. Then case control is better, followed by cohort study. So please remember, outcomes, multiple outcomes you want to know. case control is better. Sorry, multiple outcomes, cohort is better. Multiple risk factors, exposures, then case control is better than cohort. So you have to be very careful about this. You want to measure the time relationship, whether smoking came first or cancer came first. Cohort is better, followed by ecological study. You want to do incidence measurement, new cases. Cohort is better. You want to investigate a long latent period between getting exposed and getting the disease. Today you smoked, after 20 years you developed lung cancer. So in that scenario, long latent period is there. Their case control study is a better study design, is what I want to underscore to all of you. Now, what are random errors? Random errors are sampling errors. So their occurrence is due to chance alone of an observation on a sample, leading to lack of precision. So because of these sampling errors, which are called random errors that arise randomly, the precision of the study is gone. Right? So this is the population. You have randomly selected a biased sample, and that led to sampling error. Understand? Now comes, can you eliminate the sampling error? Sampling error is also called random error. Please remember, sampling error is also called random error, is what you need to remember. Random error cannot be eliminated completely. That's a point you need to remember. But they can be reduced if you do a careful measurement of risk factor, exposure, and the outcome, and make individual measurements precisely. Then you can minimize them. Now, what is the potential source of the sampling error? So the sampling error, because the sample is not the whole population. You took 10 children in a government medical college. Coincidentally, they are found to be brilliant guys. They go to temple, they put to, and they study from morning to evening, no girlfriends. But remaining 240 may be drug addicts. You don't know, right? So sample size had been too small. So that causes sampling error. Whereas non-sampling error, that means which is not random. That is because of measurement problem, behavioral effect. People's behavior change when they are being observed. Then similarly, poor sampling method, they are all called non-sampling errors, is what you need to remember. So the best way you want to reduce the sampling error means increase the sample size. Obviously, right? Increase the sample size in the study. Then you have something called systematic errors, otherwise called biases, right? Systematic errors. So what is a systematic error? There is a tendency to produce the results that differ in a systematic manner from the true value. So systematic errors are also called biases. A bias typically occurs in a systematic manner. That's what we need to basically understand. So bias is a systematic error. It can occur during data collection, data compilation, during data analysis, or data interpretation. Anytime it can occur, but bias is a systematic error. You should be very sure about. Right now. Now there are 4 types of bias that you need to know. Subject bias, the error which is introduced by the study subjects whom you are studying, right? So, for example, you are studying women and breast cancer. women, breast cancer, and the eating habit of laddus, right? But coincidentally, these women whom you are studying happen to have a lot of cousins who have the breast cancer genes. So because of that, what happened? You studied around 20 women who had genetics with a risk to cancer, breast cancer, BRCA1 gene or CRCA2 gene, but they are also eating laddus. And you thought laddus led to development of breast cancer, but laddus did not lead to breast cancer. It is the genetics. And that happened because of the study subjects by mistake had the genetic tendency, which you miss it to check for. Then selection bias, investigator bias, analyzer bias. So a bias can occur as a systematic error during any of the time while selecting people or investigating or while analyzing the data. Any of the time it can occur is what you need to remember. Now, what is an example of a subject bias? Hathorn effect and recall bias. They are the two types of bias which come under the category of subject bias. What is the subject bias? The error which is introduced by the study subjects is called subject bias. So subject bias is a type of psychological bias. So people in the group taking the placebo, which have no effective ingredient of that has a physiological effect, they are still improving. That is called placebo effect. So how can you eliminate the subject bias? People should know whether they are taking placebo or the real drug. If you tell them that by you are taking placebo, let me check whether are you improving. Then they are taking the pill, they know it is a placebo, it is not a drug, and they don't psychologically feel that they improve. So that's a subject bias. So subject bias is predominantly a psychological bias. It can be Hathorn effect or recall bias. Now comes what is meant by Hathorn effect. Hathorn effect is also called attention bias. So what do you mean by Hathorn effect? Suppose if you are being observed by somebody, then your behavior changes. So the study subjects may systematically alter their behavior when they know that they are being observed. For example, the guys are comfortable, but suddenly they know that somebody is examining them, they start dancing, right? Just like HOD is on leave, he went to conference, we are bindas. But HOD is there in the ward, then we start palpating, feeling, percussing the patients unnecessarily. So that is called Hathorn effect, which is an example of a subject bias. Apprehension bias. Typically, when the subject is apprehensive, like white coat hypertension, whenever you see a doctor or whenever you feel that you are going to the hospital, you feel sick. Today is the checkup day. Then you will start feeling sick. So the pulse, blood pressure, they all alter systematically from their usual levels when the subject is apprehensive. Then there is something called Parkinsonian bias. So typically, if you take the sample from hospital, another option is what? From the community. So if you happen to take from the hospital, right? Suppose you picked up 30 patients of rheumatoid arthritis in the hospital versus 30 patients of rheumatoid arthritis in community. Those who are hospitalized, they have more severe rheumatoid arthritis or acute problem of rheumatoid arthritis. So that sample will not be the same as the relatively milder rheumatoid arthritis in the community. So that is the reason, because of the cases and controls are different from each other being picked up from hospital versus community, there is a bias that can enter in, which is called Parkinsonian bias due to difference in admission rate and the type of sample, whether it is picked in the hospital or whether it is picked in the community, is what you need to remember. Then interviewer's bias. The interviewer devotes more time to interview with the cases compared to controls. Right? Cases compared to controls. So one of the simple example, we used to go to the HOD in our days and say, sir, we will present a case. Tomorrow we'll see, he used to say. But if our girls used to go and say, sir, please come and take the case. Oh, why not? He used to powder himself and come. So like that, interviewer bias, right? Between cases compared to controls, more time is spent by the interviewer. Then lead time bias. So typically you have done screening. Then the disease is detected by screening very early. Because of that, the patient started taking treatment, and because of that, his survival has improved. But if you have not done the screening, the symptoms are detected late, and from the day of diagnosis to the death, the time is, let us say, 1 year. But you have screened and patient lived same time. Even this guy died at 60, this guy died at 60. But this guy, without screening, was discovered with the disease at 57. This guy with screening was found to be at 51. So what happened? You will report that this guy survived for 9 years after disease detected. But here this guy survived only 3 years after disease is detected. Not because these two guys are different. It is only because this guy has undergone screening, the other guy did not undergo the screening. So the diagnosis was made much earlier, and because of that, the bias is being eliminated, is what you need to remember. Then comes memory or recall bias. Memory or recall bias. Suppose you ask somebody, what did you eat for yesterday breakfast? At most we will say idli. But if I ask you, what did you eat 1 week ago? You can't. So based upon number of idlis eaten, number of abortions happened, if you are trying to compare, it's all a pass. So that's called memory or recall bias. And this is very interesting, which is called Neyman's bias, otherwise called prevalence incidence bias. So, when did you include the people in a research study can lead to a bias. For example, you are investigating pneumonia in a case control study, and you are enrolling the cases and controls admitted in a hospital, right? By this, what is the bias that happened? People who died don't come to hospital. So you missed them. Similarly, people who have a milder pneumonia don't come to hospital. So that is the reason if you have taken the sample from hospital, you only have taken moderately severe cases, but not mild cases and fatal cases. So that kind of bias of missing of fatal and mild and silent cases and cases of short duration of episode, that is called Neyman's bias, is what you need to basically remember. Then what is selection bias? So basically, if you take groups, for example, you want to give treatment, another group you don't want to give treatment, you give placebo, right? So if the groups that need to be compared are differentially susceptible to the outcome of interest, even before the experimental maneuver is performed, that is called selection bias, or otherwise called susceptibility bias. So for example, the people who are included in the treatment group are very severe. Treatment, the people whom you wanted to introduce in the placebo group are milder, right? So what happened because of that? Even before you have given treatment in placebo and observed them, there are different outcomes that happen. So that is the reason it is called a selection bias. Now we need to know a little bit about blinding, doctor. Good to see Dr. Narottam Singh. Very good. So every day evening, doctor, we are there 6 p.m. to 8 p.m. Half an hour here and there. But today we got very late. So single blinding, double blinding, triple blinding, you have to be very sure. In single blinding, the study subjects don't know whether they are in the treatment group or placebo group. Double blinding, the study subjects and the investigator, neither of them know whether this person is in this group or that group, treatment or no treatment group. Triple blinding, neither the study subject nor the investigator nor even the analyzer who is analyzing the data, any of them don't know to which group a given individual is belonging to. That is called triple blinding. So you have analyst, patient, and investigator. 3 people. Based on that, you have the 3 types of blinding. So what is the advantage of single blinding? Single blinding, the subject doesn't know whether he is in placebo group or treatment group. That's the reason subject bias like apprehension or Hathorn Effect, all of those will not be there if the individual doesn't know which group he belongs to. So single blinding minimizes subject bias. That's what you need to remember. Double blinding eliminates subject bias and investigator bias. Triple blinding, subject bias, investigator bias, and analyzer bias is what you need to basically remember. Now, doctor, any factor which is associated with what is meant by a confounder, with both the exposure and also the outcome, and has an independent effect in causing the outcome, is called confounder. Let us say alcohol use, right? Alcohol use, lung cancer. Will drinking alcohol lead to lung cancer? They found that people who drink alcohol are found to have high lung cancer. But actually, it is not due to alcohol. The people who drink alcohol also smoke, and that smoke is causing lung cancer. So it may wrongly look like alcohol is causing the lung cancer. So that is the reason smoking is called confounder, because smoking is a factor. In this case, if you look at the smoking, smoking is associated with exposure and also with outcome, right? And smoking has the independent ability to cause the outcome. That is the reason smoking is called confounder. So define confounder. Confounder is the one which is independently associated with both exposure and outcome, and it is capable independently to cause the outcome, is called a confounder, is what you need to remember. So confounder is found unequally distributed between the study and control group. It is associated with both exposure and outcome and has an independent effect to cause the outcome. That is called confounder. So what is meant by unequally distributed between study and control group? So study group is the people who consume alcohol. Control group are the people who don't take alcohol. So in the people who take alcohol, who are the study group, smokers are higher. Whereas don't take alcohol, which is the control group, smokers are lesser. So it is unequally, confounder is what smoking. It is unequally distributed between study and control group. See, all this will come in MCQs. They'll say, is the confounder equally distributed or unequally distributed between study and control group? It is unequally distributed. Is it associated with exposure or outcome or both of them? With both of them. Does it have an independent effect in causing the outcome? Yes, sir. These are the 3 points. In the tomorrow's exam, you should logically understand and answer in the tomorrow's exam, doctor. That is very, very important. Very good to see 5 online classmates. Excellent, doctor. So please do come every day. We will be the very happy people to discover you on this channel. Now, how do you control confounding? You can do randomization, most ideal method. So the subject doesn't know whether he is going into the test group or a placebo group, treatment group, right? Then restriction. You try to limit the people who have a chance of carrying that confounder. Like, tell that alcoholic, non-alcoholic, but I need to be very sure alcoholics and non-alcoholics who are not smokers. You will selectively limit the study to the people who have the particular characteristics. Then matching. So matching is alcoholics, non-alcoholics differ in all other features. For example, 20 male alcoholics, 30 female alcoholics you have taken. Same number you will also take in control group also. 20 non-alcoholic males and 30 non-alcoholic females, right? So that what are you doing? You're eliminating the chance of sex being a confounder, being a male or female being a confounder, right? Similarly, if you are taking in the case group, in the case control, if you are trying to take in alcoholic group, 20 smokers, 30 non-smokers, even in non-alcoholic group also, 20 smokers, 30 non-smokers only you will take, so that your smoking's confounding effect is being eliminated. Then stratification is another way. You will try to divide them into mild, moderate, severe. Then statistical modeling. When many confounding variables exist simultaneously, then you do statistical modeling. So that is what you need to basically remember. Good to see Kaustav, Patra, and many more who are all online. Very good, doctor. Very good. So now comes matching. Matching means what? Select the controls in such a way that they are similar to cases, even when it comes to confounding variable also. For example, smoking is confounding variable while you are studying the effect of alcohol versus cancer. Then in alcohol, you have two groups. In this, you have alcoholics, non-alcoholics. So in the cases and controls, if you take 20 alcoholics and 30 non-alcoholics, even controls also you should take 20 alcoholics and 30 non-alcoholics. If you do that, number one. Second, you should take 20 smokers, 30 non-smokers. Here also you take 20 smokers and 30 non-smokers. Of course, you are investigating alcohol, for example, then you don't do the matching for the alcohol. You felt smoking is the confounding factor. So smoking distribution must be similar in cases and controls. Then the confounding effect of the smoking is eliminated. Then you can comfortably check for our alcohols are more in cases or not. If they are there, then the odds ratio is, if you take alcohol, you may get cancer. Right? So matching is such that all other parameters are matched, except the risk factor which you are studying. Then you will check whether the risk factor is higher in the cases than controls. If it is higher, then the odds ratio is high, and the chance, then you can say that risk factor led to the disease. All right? So matching eliminates confounding. Another classical example. Rate of ice cream consumption, and you are studying sunburn. Then you are thinking, why the people who are consuming more ice cream are having more sunburns? How is that possible? But the reason is, the people who are consuming more ice cream are on the beach with very high temperature. That is causing the sunburns. So how can you manage this situation? High temperature is what? Confounding variable. So that is the reason, take the people who are consuming ice cream, more ice cream, in a Himalaya, and then check whether sunburns are higher. Then you will find that sunburns are not higher, because the confounding factor, hot temperature, which can cause sunburns, which is associated with both the ice cream consumption and sunburns, hence it is a confounding variable, has been eliminated. That's a point you need to basically appreciate. So finally, matching. Matching is not blouse and saree matching. Matching purpose is to distribute the confounding factor to be equally present in both the case group and control group, is what you need to basically remember. Then you have something called caliper matching. Caliper matching. So you are trying to do matching wherein there is certain specified distance for a particular variable. Variables are of two types. You should know, doctor. Variables are of two types. One is called discrete variable. Other is called continuous variable, is what you need to remember. What is a discrete variable? If the answer is yes or no, it is called discrete. For example, pregnant or no pregnant. There can be slightly pregnant. So pregnancy is what? Discrete. Abortion or no abortion. There can't be slight abortion. Of course, there can be slight abortion. This is not a good example. Pregnancy, no pregnancy. Best example of discrete. Are you black? Are you white? You can, of course, this is also continuous variable. You can be in the middle of the two. Chaman chaya. Let us say, are you a topper from the top of the merit list or bottom of merit list? This is perfect. Possible. Qualified, not qualified. Is a discrete. Continuous means height. I can be 5 feet, 4 feet, 6 feet, 7 feet, 3 feet, anything. I can't be 0 or 5 feet, no? So it is not yes or no type. That is called continuous. Age, I can be 23, 24, 25, 26. I cannot be like 0 or 25. I can be anything, right? So height, weight, right? IQ, intelligence quotient. I can be a moron, I can be idiot, I can be brilliant, I can be genius, I can be super genius. I can't be 0. So that's called continuous variables. So whenever you have continuous variables, you do caliper matching. What is meant by caliper matching, doctor? Caliper matching. Suppose you have taken case group, control group. In case group, you have all 27-year-old, right? So if you take 50 27-year-old people, what is their mean value of age? 27 only. All 50, each of them are 27 means their mean value is 27 only. Whereas in this group, you took 50 group. This is also 50 group. In this 50 group, 25 are of the age 25. And another 25 are of the age 29. So their average also will come to 27. Here, everybody is 27. Here, half are 25, half are 29. So average came to 27. So you have still done the matching, but not exactly, but with some range to this age, which is a continuous variable. That is called caliper matching. So if you have 50 people each of 27, the other group need not have everybody of 27. They can have 50% 25, 50% 29, so that the average turns out to be 27. That is called caliper matching, is what you need to basically remember. All this is bakwas, doctor. I'm telling you. Preventive medicine is very boring. Statistics are super boring. But for entrance exam, we have to accept all kinds of fists, punches, lashes, everything given by the examiner. First time only it will be like this. After that, second time. So let me tell you, 60,000 points, which I give you, tomorrow's 200 marks will be from this 60,000 points only. If you master this 60,000, you are the top of the world. right? So I will give all this as a notes, each point 348, 349, point to point as a notes. So please do call our helpline to get the relevant notes so that your revision become very focused, super focused. Now, what is meant by frequency matching? You should see that the frequency distribution of the matched variable is similar in study and comparison groups. That means if 15% cases are under the age 20 in cases, even in controls also, you should take that the 15% of the cases are under the age 20. For example, cases you have taken 100, controls you have taken 1000. Then 15% of 100 is what? 15. 15% of 1000 is 150. So if you have taken 15% under 20 in this case group, control group also you should take 15% under 20. That is called frequency matching, is what you need to understand. Then comes category matching. So for example, you are trying to take cases, controls, right, in a particular study. Let us say in this 20% doctors, 20% nurses, 20% ward boys, 20% diamas you have taken. Each is a category. Similar kind of category should exist in control also. That is what category matching means. Then individual matching. So, for example, in the case group, if you have taken Albert Einstein-like guy, there should be a similar Tesla or a Albert Einstein-like guy in the control also. So individual matching, that's called as. Then pair matching. Pair matching is commonly, we do it in IPL. 5 very good bowlers are there, means in this team also 5 very good bowlers should be there for it to be a perfect mukhamukhi. That's all is about that app, no? Dream Team, right? Dream 11. Then randomization. So one method is matching. You have matched the variables here and here and then compared the two groups. That is one method. Second method, you took all the people and randomly assigned them without their knowing into which group they are going. So is randomization better or matching is better is the question. Randomization is superior to matching, superior to blinding, and randomization is the Raja, king to eliminate the bias, is what you need to basically remember. So what is the unit of a randomized control trial? In randomized control trial, we are basically using the patients and ascribing them into treatment group and placebo group. Then there are 2 types of randomized control trial. One is called concurrent parallel design, other is called crossover design. So what is the meaning of that? Always there are 2 groups in randomized control trial. One is called experimental group, other is called the reference group. Reference group receives placebo. Experimental group receives treatment. So if the people who are the part of the treatment group and the placebo group continue in the same group until the end of the trial, that is called concurrent design. Crossover design means Half of the study, they are in the treatment group, and another half of the time during the study, they are in the placebo group. Then they moved into treatment group. That is called crossover design of a randomized control trial is what you have to basically remember. So why do we do crossover design in randomized control trial? Very simple. Let us say there are poor people, there are rich people. Suppose rich people, you started cancer chemotherapy. Poor guys, you did not, you put them in placebo group. Suddenly somebody will tell, ha ha, मैं गरीब हूं इसलिए मुझे प्लेसिबो में लगाया, वो अमीर है इसलिए उनको वो नॉवेल ड्रग दिया. To avoid that, what will you do? भैया तो गरीब हो या अमीर हो मुझे फर्क नहीं पड़ता, right? Half the time you are going to receive placebo, another half of the time you are going to go into the treatment group, and we are doing crossover trial. So crossover design helps to remove the ethical concerns is what you need to basically remember. Intention to treat trial. What is the meaning of it? So basically, in a randomized control trial, when you are conducting, there is one treatment group, one placebo group. Suddenly, placebo group people said, "Arre, hum bakra ban gaye aapke haath mein." We will not continue in the placebo group, and they dropped out of study. So that's called attrition. Then the people who are in placebo group moved into the treatment group. So intention to treat trial means it is a randomized control trial where the results are not affected by this crossing over, or the results are not affected by attrition. That's called intention to treat trial, ITT, it is called as. So what is the main purpose of randomization, randomized control trial? You want to remove the selection bias. वो मेरा भैया बोल के मैंने उसको ट्रीटमेंट ग्रुप में नहीं ऐड किया, वो मेरा ब्रदर इन लॉ बोल के उसको ले जाके प्लेसिबो ग्रुप में नहीं डाला. Randomization made them to go into placebo or into treatment group. So selection bias is eliminated. So randomization of the randomized control trial. What is the meaning of randomization? Dividing the people into an experimental group who receive the treatment or intervention and a reference group who receive a placebo or the intervention is not given is called reference group. Randomization is known as the heart of the randomized control trial. Thank God it doesn't have a head, tail, ears. Randomization purpose is it removes the confounding and bias is what you need to remember. So how do you do randomization? Ina mina bika. So you will assign each of them a random number, and then the computer will pick up the random numbers and push them into the two groups. So it is done with random number tables is what you need to remember. And why randomization is superior to matching? In matching, you are only bringing a homogeneity in the known confounding factors. See, because you know that smoking has a confounding effect, you ensure that smoking is not there in both cases and controls. But you don't know there may be some other things like genetics, etc. Best is what? You take everybody and let random number table decide which group they go into. Exposure and no exposure. So that is the reason randomization, both known and unknown confounding factors are made to become equal between the two groups that you are observing. That's the point you need to remember. Then what is a pre-post clinical trial? Pre-post means simple. There is no control group. So typically, patient act as his own control. Every patient has a pre-test score, that is before taking the drug, and post-test score after taking the drug. And you try to check whether the two scores are differing or not. Suppose in the last entrance exam you got 10,000 rank. You took coaching, you got 20,000 rank. Next time, then you will know how much coaching spoiled your life, right? So, pre-post clinical trial, that is very, very important. So, why do we do pre-post clinical trial? Basically, to know whether the knowledge, attitude, or pre-existing risk behavior, do they change if you start the intervention? That's the reason before starting intervention, you are taking the baseline values. After starting intervention, you are monitoring those base values. So that is the main purpose of pre-post clinical trial. But pre-post clinical trial has some limitations. Suppose after starting the treatment, if the patient dies, you don't have any parameters to check. So it is not good if in the studies involving mortality, because post-test won't be available. So here you have done biopsy, here you have done autopsy. You can't compare biopsy and autopsy report, right? Right? So pre-post control trial cannot be randomized, because the same guy is before treatment, after treatment. There's no chance of putting him in placebo group. That's the reason randomization is not possible in pre-post clinical trial, is what you need to remember in the tomorrow's exam. So, doctor, phases of clinical trial. Every entrance you go, no, doctor. Last 30 years I have been watching the PG medical entrance. I myself is a topper and made thousands of people become toppers. Clinical trial phase, different phases. If you do mistake, you're gone. Right? And definitely they will ask. Phase 0, you do on healthy human volunteers, and you are looking for micro-dosing. Right? And generally 10 people you do it. And it is typically monitored by a clinical researcher. Scientific researcher is different from clinical researcher, remember. Scientific researcher will do on mouse, rat, and everything. Clinical researcher is a guy who did his M pharmacy or MD pharmacology and does on 10 people. And it is small and it is subtherapeutic. Mainly what you are testing in phase 0, pharmacokinetics. You are testing, particularly oral bioavailability, half-life of the drug. They are the things that you are looking in phase 0. Before phase 0, what do? You do preclinical trial. Preclinical. Here, you are testing the drug in non-humans, like rats, mouse, rabbit, monkey, etc. So whole purpose is what? Of preclinical trial. Preclinical trial, why do we do in animals? Basically, to know the efficacy. Right? What is meant by efficacy? There is one drug A, drug B. Right? You have given same dose of drug A, drug B, but one drug caused higher effect than the other drug for the same dose. One drug caused higher effect than the other. For example, you are looking for 2 beta blockers. For the same dosage of the beta blocker, one beta blocker slowed down the heart rate by 10, but other slowed down by 30, right? So that is called efficacy. Potency means what? You have taken two drugs to achieve a particular effect, like slowing down of the heart rate. One drug achieved it at smaller dose, another achieved at a larger dose, right? The one who achieved at smaller dose is called more potent. So here efficacy is fixed while calculating what? Potency. While calculating efficacy, the dosage is fixed and you are observing the effect. Dose, for the same dose, what is the difference in the effect? That is efficacy. For the same effect, how much dose was needed? That is potency. You'll remember, right? Anyway, we'll discuss in pharmacology. There's one excellent teacher in pharmacology by name Dr. Kushbu. She's going to teach, right? So, preclinical studies, main purpose is non-human subjects, efficacy, toxicity, pharmacokinetic information. That is what you are doing. Done by scientific researcher, no human subjects. It is done in vitro lab, and it includes testing in model organisms, etc., etc. Or similarly, cell lines of the humans. You are trying to test for the virus, cytopathic effects of the virus, cell lines of the humans, right? So you will take the alveolar lung, alveolar cells. In that, what is the effect of this particular drug, right? So that is cell lines. Then comes phase 1. Phase 1 is done on the healthy human volunteers. You are testing safety and non-toxicity profile. So that is phase 1 clinical trial. Safety and the pharmacokinetics. Generally, it takes 1 to 2 years. Right? Then, so phase 1, what is the specific thing that you do? Dose ranging. The range of the dose that you can give in the healthy volunteers for safety. How much you can give. Similarly, clinical researcher performs 20 to 100 healthy volunteers or cancer patients. Cancer patients, you check cancer drugs, but 20 to 100. Either normal healthy volunteers or the patients. Then it determines whether the drug is safe to check for efficacy. That's what you need to remember. All right, doc? So then comes the phase 2. Phase 2, you look at the efficacy. You do it on patients. That's what you need to remember. So typically testing of the drug on the participant to know the efficacy and side effects. Phase 1 is for safety. Phase 2 is for side effects and efficacy. Here, therapeutic dose, phase 2. Phase 1 is subtherapeutic dose, but you will be giving ascending doses until therapeutic. But here, only therapeutic you will give. And then look for the efficacy and side effects in phase 2. 100 to 300 participants. So, next comes the phase 3. This is also done in patients. You are comparing it with existing drug. Right? This is called phase 3. 1,000 to 3,000 participants. Once it cleared phase 3, definitely oseltamivir is better than ribavirin is better than Tamiflu, you are comparing one to the other. That's what you are doing in phase 3 clinical trial. Then it is submitted to the FDA approval. That's what you need to remember. Then phase 4 is, that is also done on patients to know the long-term side effects. So that is the reason phase 4 is also called post-marketing surveillance. You have given the COVID vaccination to a large number of people. To a large number of people. That is what you do in phase 4. So now comes certain interesting questions. Phase 3, 4, 1, 2, 0, which is a randomized control trial. You are comparing one drug compared to the other. Where do you do that? Phase 3 is an example of RCT, is what you have to answer in the tomorrow's exam. Whenever you launch a new drug in the market, after you launched it, that is what, so when will you launch in the market? After phase 3, FDA reviews and approves, then you launch in the market. The longest phase of all is the phase 4, because it takes few years before you know that how many side effects are there. So post-marketing surveillance comes under phase 4 clinical trial is what you need to remember. And when will you, in which level you know maximum tolerated dose? So you start subtherapeutic and slowly increase it to reach the therapeutic. That is what you do in phase 1 clinical trial. So these are all the different ways of asking the question. So doctor, with that, we will conclude today's wonderful evening with Kaustav Patra and Narottam Singh. Please do come tomorrow, every day, evening 6 to 8 p.m. and also call our helpline in order to get your notes. Thank you very much.